It's my pleasure to introduce Mike. I've known him well for as long as I've been involved in the BPA. He's the lead in the Porphyria Centre and the NAP Centre in Cardiff. He was very much involved in setting up the National Acute Porphyria Service. He's also been very much involved in setting up EPNET, the European Porphyria Network. And they've always been very welcoming to patients. And I'm glad that the main EPNET board now has a patient representative on the main board, who's our own Liz. So I'm very glad to ask him to lead this interactive session on porphyrias.
Thank you, John. Just saying about our interaction, we held a meeting in Cardiff in 2013, and I think that was the first time we ran a parallel patient day and a science day, and we made the mistake of sending the patients up to this lovely room in this university, and it was a lot of EPP patients there, and it was one of these quite modern buildings, and the sort of top corner was a glass box. And you could work out who the EPP patients were who attended, because everyone was out there looking at the view, and all the PPP patients were in the far corner, shielding themselves against the light. Anyway, thank you very much. I'd like, if we can, to be as informal as you want. I have prepared some slides. We don't have to stick to them. I prepared some introductory information, because that's what we do for when we teach medical students or specialist doctors, of course, many of whom know little or nothing about porphyria. So we start from the basics, but you kind of like expert audience in a way, and probably know more than most of the medical students I teach about you definitely know more about protoporphyria, and probably porphyria as a whole. So we don't have to go through, I don't know how that's happened. I don't know whether you want me to go through some basics first, or do you just want to head straight into an interactive? What I've tried to do is think about some questions that people ask me in clinic, and then maybe explore whether those are the things you want to ask, or whether obviously there will be a time to ask anything you want as well, and I will try and answer if I can. Sorry, you want some of the basics? Okay, so this is a porphyria where the photosensitivity that you experience, the intense pain, is caused by this specific porphyrin called protoporphyrin. Most of it's coming from your bone marrow. That's why we call it erythropoietic protoporphyria. That's where the red blood cells are made in your bone marrow. But there's a small bit that probably comes from the liver as well. So what happens is that this protoporphyrin molecule, when it's circulating in your skin, when it's close to the skin, it can absorb light. And that light is of this wavelength here. So it's just in the visible range of the spectrum of light. So you all know that white light, if you open it up into a spectrum, goes from red, yellow, green, blue, and violet. So it's in that sort of violet range. And when it absorbs light, that's energy. And that's not the problem. It's when that porphyrin releases that energy, it releases it as chemical energy, and that chemical energy is what damages the skin. So most people experience their first symptoms in childhood, usually under 1 year of age. Anyone here with later onset, later than that? Or do you all remember being when you were very young?
Our sons actually suffered. He wasn't diagnosed at 8.
Yeah, so we know that the diagnosis is much later, but that's...
But you had no problems?
No problems until then, okay. Well, that's quite good. So a colleague of ours in Cardiff did a study about 12 years ago now, and he saw 235 patients EPP, and he found out that they all said most of them had symptoms by the age of 1, but of course we all know the diagnostic journey, and it can take many years for the diagnosis to be made, and some of that is more difficult and more traumatic than others, those journeys. It's rare, as Anthony said, So probably about 1 in 100,000 in the United Kingdom. So you're a good representation of quite a lot of the UK. And you all know this. I probably don't need to dwell on it. What was interesting to me was that some people use hot water to get relief. See some nodding. It's quite interesting. What made you try that? Have we got the mic?
Yes.
For me, once I'm affected, it's about temperature control to then minimise the symptoms, although I have to say I've not suffered now for a lot of years because I'm in control of my own life. I wear gloves, I wear a hat, I wear Dundee cream. I don't go out a lot, I do manage it that way, but I really haven't suffered these symptoms, and it's funny to think about it now, and sometimes I think, I think we all think at the beginning of the year, are we cured? Are we going to be all right this year? Because you've been all right for a while and you think, I'm actually going to be okay, and then you find out that you're not. But I manage it, so I don't have to deal with it anymore, and I can't remember the last time I treated it. But when I did used to suffer, especially as a child growing up, and then also when my kids were little, and you're out a lot more, I just found that once the pain starts, the only way to deal with it was to try and get myself into a little cocoon as warm as I could stand, and then you manage the pain that way. And then I found that hot water helped that. So you put your hands into hot water as hot as you can stand, and then when they come out. And also I always found if you use hot water, you don't get anywhere near as much swelling as you do with cold water.
Another comment?
That's the same experience my daughter said.
Yeah.
She said, when I have cold water or cool packs, my skin will be swollen more and more. So she said, I go in as hot as I can. And we have one patient, she said, when I have pain, I go in I don't know the English name, sauna.
Sauna.
And she says, it's pain at first, but it helps me.
Interesting, isn't it? So this is one great thing about these sessions, is that you learn from other people. Children, I don't think your parents are going to buy you a sauna, but you can try. Okay? So that kind of describes it. And people with time will develop chronic changes in the skin. They're usually very subtle. They're little scars on the faces from repeated acute episodes of sun exposure. And what we know from Dr. Holmes' study many years ago, he was the first one to actually do a quality of life score on patients with EPP and showed that people's quality of life was severely affected. That's been duplicated elsewhere now. Of course, many people do quality of life studies, all sorts of diseases. So, I'm mixing up my microphones, I think. So, in terms of diagnosis, it's relatively straightforward as long as we get one of these, a blood sample, because it's a porphyria, unlike all the others, in which there are no changes in the urine. And we know that this is a common error amongst general pediatricians and doctors and things, because they all remember urine, porphyrin, that's how you test it. And so we know of children who've had only urine tested and been told they don't have protoporphyria. But in fact, you won't find anything abnormal in the urine of any patient with protoporphyria. So this is what we need, which is blood, and we look for, we excite, just like when you get a reaction to sunlight in your skin, what we do is we put the specific wavelength of light through a narrow beam into your serum, and we look to see what light comes off, and if it comes off at this specific wavelength, that's protoporphyria. So it's actually quite a simple test, and you can see here, typically, it's not difficult to find, because it's absolutely clear that there's a large amount of protoporphyrin circulating in the clear part of your blood, which we call serum. So this is the key when I teach the dermatologists. That's why it's in red. we don't want urine. If you only can send one sample, it must be blood, okay, for all the skin porphyrias.
Hello, Richard Byford. Just querying whether you need to actually protect the sample from light before it's tested for fluorescence.
Well, we encourage all the samples. We ask laboratories, other services who send us samples to treat all the samples the same, which is to protect them from light. Whether light exposure would completely demolish all the protoporphyrin in a whole tube of blood within a couple of days, I don't think so. But what we don't want to give out is mixed messages. The message is all samples should be collected. They can be collected in the light, and then once they're collected, they should be labeled, and then they should be covered in some form of either tin foil or a dark envelope or something, so that in their transit to the specialist laboratory, they don't undergo lots of light exposure. So we basically, that's the message to every lab, and pretty much they do understand that. The delay with the light covering is usually between when the sample is collected and it getting to the laboratory. So we work in a sort of dim light environment, and we use a special piece of equipment to measure this is called fluorimetry. So we're measuring fluorescence. So where you excite with one wavelength of light and you see an emission coming back at a different wavelength. And of course, the other thing just to say is that not every laboratory would have one of those fluorimeters. That's why there are only 3 or 4 specialist laboratories in the United Kingdom who would have that kind of equipment. It's not particularly expensive, but it's not really used for anything else.
I'm a GP. Can GPs request that, or is it only through
No,
specialists like yourself?
No, we get them from all over. Whether your local laboratory will agree to it, that's up to them. But they send, almost all of them will send it on to a specialist service like ours or King's to be analysed. Because, as I said, not many laboratories would have the piece of equipment that does fluorimetry in their laboratory. So, genetics. We now know that 3 genes are involved with this condition. Probably most people here have this gene involved, ferrochelatase. It's about 94% of patients with protoporphyria. About 2 to 4% have this form, which is X-linked, so that it means that it's carried on the X chromosome, and it means that so typically a father cannot pass it on to a son because they can't pass on their X chromosome, they pass on their Y chromosome to their son. So it's a slightly different inheritance pattern, but it's also quite an unusual condition. Even so, you can work out if it's 1 in 100,000 and only 2% are XLEPP, it is, I think we've got about 20 patients in the UK with this one. And this one, recently described as extremely rare. I think there's only 1 family described to date. So, but as I said this morning, we're starting to work out some of the unexplained things that we knew about when Dr. Home did his study. We thought we didn't find mutations in the ferrochelatase gene in some of the patients, and so we thought, that's odd. Is there something wrong with our methodology? But it's come. Then you start talking to other people. No, we've got 1 or 2 patients who don't have mutations. So this is where the collaboration internationally comes into play, where you discover new things. So why we talked about this morning, so happy to go through it a bit more. Genetic testing, well, we don't really know that much about XLEPP because it's quite new, so we think the biochemistry is distinct, but to be certain we're still doing genetics on them. But the main question we get for the reason we get asked to do genetics in EPP is usually, will I have an affected child? It's not that I don't think people wouldn't not have, well, I hope they wouldn't not have children. I guess it's down to individual choice. But I think it's there to help people make that choice, which is what counselling is all about. And quite often, if we know a parent is affected or an individual is affected, because we know how the genetics works, we sometimes just test the partner for the common error that usually causes the porphyria. So in EPP, most patients will have a mutation, a pathological mutation, which causes virtually pretty much no activity from that copy. And on the other copy that they will have what the French have described as this low expression variant. And the point is that that low expression variant is relatively common in the general population. It's carried by about 10% of the population. So if you have EPP, whether you will have an affected child is dependent on whether your partner has this. If they don't have this, then the risk is down to that of the general population. So,
When did that become known?
in about 2002, 2003. Yeah. And actually, that took quite a lot of work to prove it, because it's quite a complicated and slightly unusual situation, because the mutation is in the non-coded region of the gene, and it affects splicing, but not 100%. So it's like a mild mutation. So there is still some function from that. If you have that in your gene, there's still some functioning of that gene. So that, similarly published in Nature, because it was almost unheard of at that point, that kind of mechanism. It was a new mechanism that was being described. Does anyone want to ask anything about genetic testing? Following on from this morning's discussion.
If Ava has a mild EPP, she's better off than some people. Would she have if she had a husband with a low expression variant and they had a child who had EPP, could she have a child with severe EPP, or because hers is more mild, would her children be mild? Does that make sense?
It makes sense. I don't think we have an answer. No. I don't think it's that predictable yet. As far as we know, for most people, it will be, I suppose you could look at her mutations and see, because even amongst the what we call null mutations, there's some variation in that. But I don't think it's that predictable in genetics, to be honest. So I would suggest that unless things change and we learn more about individual mutations and whether they correlate with disease severity, at the moment we treat everybody as the same, with the same level of risk.
My question is still going back to understanding how our son got EPP. So how it's been explained to me is my husband and I both had the low expression variant, and because
it's unlikely.
And then it was the luck of the draw that he has developed EPP and my daughter hasn't. But you're saying it's unlikely.
The most likely explanation is that one of you has a null mutation which you can carry, because whoever's got that has 50% activity. So the other allele is being normal, is sufficient to make enough heme that you will never have a problem. And the other parent, I don't know which one is which, probably has this low expression variant. And if your son inherits the mutation and the low expression variant, he has it. If he inherits the variant, only he doesn't.
So that's where the luck of the draw between
it's like flipping a coin each time, unfortunately. And people sometimes think you can have more children, the risk diminishes, but it doesn't. Each time, it's 1 in 4 chance.
And my daughter's older.
Yeah. It's very unlikely with age that you will. I mean, some people do develop symptoms later on in life, but it's less likely. But if you want to be absolutely sure, genetics is the only way.
Why are some people more exposed to or
Like more severe.
why are some more severe than less? You know, like this lady's daughter only got a very mild variant. Why are some people got very low tolerance to some?
We don't actually understand that. There is some correlation between the level of erythrocyte protoporphyrin and severity of symptoms. So we know that when people's symptoms sometimes get worse over a period of time, that predicts often that their protoporphyrin levels are starting to rise. And we see that as a warning sign that maybe your liver's getting less able to excrete it, so the liver's being damaged. But we know as well that you can have the same level of protoporphyrin when you're pregnant and have no symptoms at all. How do we explain that? So we don't know what other factors are involved with people's different experiences in terms of symptoms and why some. Perhaps it's also to do with the texture in the skin, the natural protective factors in the skin. After all, there's some treatments which give you additional protection which seem to diminish symptoms. Perhaps some people have better innate or their own protection that means they experience less symptoms. But no, I'm sorry, we don't. Perhaps in the future we might be able to start understanding. Maybe there are other genetic factors which impact on, in other genes, which impact on why you're more severe than others, yeah. I'll come back to you. I'm going to let this lady ask at the back.
Hi. I was just going to say we had genetic testing done after James had been diagnosed, and I fell pregnant with my 8-year-old, and she came back that they tested her cord blood and she carries 2 good genes, where my husband carries the variant and I carry the mutant. And then my youngest daughter, she has gained her dad's a variant gene but won't ever suffer because she didn't get my gene.
She won't if she didn't get your gene?
Yeah.
Yeah. Thank you. So that kind of sums up, it's quite complicated, isn't it?
Yeah.
Yeah, yeah. So, but that's the tip. That is actually, in the UK terms, that's the typical. One parent carries the severe mutation. You carry this mild variant. Unfortunately, you're blaming them, I'm sure, for all of this. So, is there someone else who?
I just wanted to know about when I was on iron, I was more susceptible to the sunlight than, so whether it is a liver issue makes you more severe or not, I don't know.
Can you remind me to come back to iron, because it's in one of my other slides, because we need to talk about iron. Okay, because that's starting to become a little clearer now. Did you want to make a comment?
I was just going to say that I definitely felt I didn't suffer symptoms when I was pregnant. I'd forgotten that because they're 23 and 19 now, so, but yeah, it's odd. But I know a friend who is allergic to cats and she didn't suffer any symptoms while pregnant either, so maybe it's magical and it protects you from things.
Pregnancy is a cure-all, is that what you're suggesting? Hopefully not. Yeah. So, this is a list of common questions that we kind of get asked in clinic, and I don't claim to have all the answers, but is this the sort of thing that people were thinking the session would be about? And we can ask any others you want to. We've got a little bit of extra time today because the gentleman who was going to come and talk about SENES is delayed, and so we can carry on until the next session. So, or not. If you've had enough of my voice training on, please just say. You can have a go with the mic. So, managing the pain of a photoreaction. This is not something that I really do. So, all I know is that patients have told me that once you have one of these severe episodes, you're basically sitting it out, and most pain relief doesn't work. Is that what people experience?
I just wanted to just share my experience, how I've dealt with it previously. So the pain gets that bad that I basically have to live it out, and the only thing that can relieve me is actually if I go to sleep. But I have to physically get worn out in order to do that. I don't know if anyone else has to do that too.
Any other strategies? Has anybody ever found over-the-counter pain medication helpful? No.
The only thing I found that helped was I made my own aromatherapy cream with peppermint and lavender in. And so when the skin was sore, putting that on gave some relief. But that's relatively recent.
So, Brufen, paracetamol, no point. Is that what, or does it help a little bit? No.
I'm just really adding to what Victoria said. I was caught out in the middle of Wales. And in a hotel, and they called the local GP in, and I explained to him what I got and said, I don't expect you to really have a lot of experience of this. He said, well, you tell me what you want. And I said, well, can you make me go to sleep? And he said, certainly. And he didn't use anything heavy, but he gave me some tablets from his bag. I went to sleep very quickly after he left, with supervision from the staff in the hotel. I woke up very, very stiff, but it had gone overnight, and it was one of the worst attacks I'd ever had.
Yeah, so sleep then. I mean, these are all, I think what we're kind of coming to is that I don't think that there's much that doctors, once you've had that reaction, once it's set in, there's really very little that will relieve it.
My son, the best relief that he finds is a fan, because even putting like cold flannels on or anything, he can't sort of bear that. And also the other thing which we've used is Emla cream. Do you know the numbing cream? Just rub that into the back of his hands and on his nose, and he finds that helps as well.
Okay. Has anyone tried? Apparently, there's like a menthol cream that the dermatologist can prescribe, but I don't know whether it's ever been tried in EPP. No one's ever tried that. Okay. It's like a menthol cream. You know, that stuff that it sort of feels like it's cooling and evaporating. Yeah. No.
Going back to my son, because like I've just said to my husband, you don't know the pain that he's experiencing. When things first came to a head with him, we were in Italy, and I realised that something was wrong. He was crying out in pain, and he would take himself away and douse himself with water, so I knew it wasn't a tension. Anyway, we ended up A&E in Perugia. No one knew what was happening, but a doctor actually said, I'm going to give him some steroid tablets just to get you through the week. She says, I've got an 8-year-old son, I know this would help. He seemed to be fine because we continued for another week. Does steroids actually have any sort of benefit?
I think it's very unlikely, other than reducing swelling and any inflammation under the skin. Was it a topical or an oral one? Oral, okay. I'm not aware of it. I guess in an acute, but you can't keep going with it because they're given in very short courses, so it's not really. Yeah.
On steroids, I actually forgot to add that when I used to end up in hospital with severe reactions, they did used to give me steroids, but it was along with sleep medication too. So I don't know. I've always kind of suspected that they may help. Did seem to, but yeah, he's the professor.
I don't. The thing is that these are anecdotes that people try. I'm not aware of anything in the literature suggesting that steroids would help, because I think they would only really be used in an extreme situation with swelling. And I think it's because of the swelling probably that the doctors would have assumed that it was some kind of allergic reaction for which steroids are used. Yeah. And it would have dampened down that reaction of a severe episode, I'm sure. So, what else do we get asked? How often should I be seen, and what routine blood tests should I have, and how should I look after my liver? So are we aware of the sting in the tail of EPP being the liver? Okay, so how often should I be seen? So do people here see a specialist, or do you see a general practitioner or specialist? Okay.
I see
You see Prof Stewart?
We see Dr. Linga in Salford Hospital.
Okay.
We used to see him every 6 months, but he's gone back to seeing her every year now.
Okay, so do people get seen very frequently? 6 months, okay. Every year, yeah. I think it should be down to the individual. Once we offer our patients whatever frequency they want, but it's often to see a specialist, unless you happen to live in their catchment area, it's a long way to go. And often it's just a chat, because you wouldn't do blood tests necessarily more than once a year. So I think it's down to convenience. I don't think there's a right or a wrong period, and it's a matter of also how comfortable you are about managing your own illness. And you may think, there's no point in going and seeing Dr. Badminton in Cardiff once a year, even if I'm not getting anything out of it. After all, we've got to remember that a lot of people now are very happy to be contacted, and certainly we are, by email or phone or whatever. And I try and encourage people to do that. If you have a question, phone. And I get quite a lot of phone calls during the week from patients and clinicians asking about porphyria.
With James's testing, he has his liver function, vitamin D, they do his iron. I also get him to test his calcium because he's been calcium deficient because of his vitamin D being deficient. Do they have to test his iron every time he gets tested? Because then I have a fight on my hands with the GP who wants to prescribe him iron and then get called a bad mother because I'm refusing to medicate my son with iron.
We'll talk about iron next then.
Hi everybody, my name's Fiona and I'm Mark's wife. Mark has got EPP. In relation to telephone calls, I made a telephone call to you may not remember, about 7 years ago, and Mark was taken into hospital with what was, we now know, an appendicitis. Now, because of the EPP, it was really, really touch and go. And through the night, I'm getting really emotional about it because it really was life and death. And I couldn't get hold of Prof Stewart. And I thought, who can I get hold of? So I'm trying to get out all the medication. And he's really, really fighting for his life. And I got the medics. And the pressure I had to try and get those medics to ring somebody who knew about EPP, it was awful. And I spoke to you and you said, no, he's got an appendicitis. He just needs to be operated on. It isn't the EPP, because they were saying, no, it's EPP. And he also threw a spanner in the works because his appendix was on the other side. So they couldn't see that. So it couldn't have been any more complex. And it was, no, well, it could be an EPP breakout. And I say, it's not. I know what it's like. It isn't this. Please, will you just get on with it? And it was you who actually spoke to the medics to then say, operate on this man, operate immediately, and also gave them the protocols of the light in the operating theatres as well, which is really important if your children have to go under the knife or have surgery. So thank you very much.
Well, thank you for that. We might need to cut that out of the video. All the thank yous. It's a bit embarrassing. But anyway, that is the point. I think that illustrates a good point. You as the patients are the experts. Most doctors that you come across will not have seen a patient with EPP, the vast majority. And you do have to learn to stand your ground. I'm sure there are other people here who've had to stand their ground as well. Because it's something which they don't come across. And you raise the other point is that they often muddle acute porphyria with everything else. Not just the testing of the different porphyrias, but also how they're managed. And we get quite a lot of calls about, can my patient have this drug, can they have an anesthetic? And when we find out which type of porphyria it is, it's not an acute porphyria, we're able to reassure them that they can go ahead and there are no risks. So, it is helpful if you know someone, you know the contact details for someone who works on porphyria, because they're usually able to cut straight to the chase with the clinician. Now, I'm the first to admit I'm not a general practitioner. And they are experts in their own field. I'm not a surgeon, they're experts in their own field. Our job is to help them do their job on a patient with porphyria. That's all. We're not better than them, they're not better than us. We should be working together for those patients with rare disease, with a rare disease. So, what we do in Cardiff, initially, we would see a patient a few times after the initial diagnosis, but then we offer them an annual visit. Most are happy with that. In the spring, to make sure that whatever their treatment wishes is going to go ahead. So we see them in dermatology. I would suggest you should be seen by a dermatologist, preferably a dermatologist who specializes in photodermatology. We do measure the blood porphyrins each year. If they start going up, then we do worry a bit. We measure blood count and ferritin. We do a liver function test, and I've put FibroScan here. This is a very simple test that is increasingly available, which looks at the elasticity of the liver. So it's looking for scarring of the liver, which are early signs of liver damage. And certainly, you don't need this every year, but possibly once every 2 years, that it is a helpful test to make sure there isn't any slowly developing scarring of the liver. Let's talk about iron. Okay, so because there's a lot of misunderstanding about it, and there's also, the problem is that some people do respond badly to iron, and that the iron level, their protoporphyrin levels go up, they get worse photosensitivity, they also then may have some abnormalities in their liver test, and that alarms the patient, but also alarms the doctor, and we have a few calls every year about that. So I'm sensing that you've also got this uncertainty in your own cases. Is that correct? Does anyone want... So you mentioned iron earlier on. Do you want to repeat what you said?
So I've had various tests, cameras going up and down, just to see what the issue is with my anemia. They're not quite sure if I was bleeding internally or whatever, because I'm so low. In the end, after going to various different departments in hospitals, I'm now on 1 iron tablet a week, which normal people have 3 a day, I believe. That seems to help. I'm not so tired as I have been, and I've struggled going up the stairs, but that has helped now. But try to explain to a GP that you can't have iron, and they just want to give you iron because they're so worried about you, is really difficult. But it seems to have worked now. I feel fine. I've been through the summer with it on having 1 a week, and I haven't caught the sun anymore. A few years ago, I caught the sun really bad when I was on lots of iron. So.
Okay, can I make a comment about that? Sorry, I was just trying to find the slide. So, anemia is common in protoporphyria EPP and XLEPP, and what we worked out a few years ago is that there's something unusual about the way iron is absorbed, stored, and used to make heme. Whatever that mechanism that doesn't quite work, what it means is that most people have a slightly lower hemoglobin and a slightly lower ferritin than the general population. So when GPs, and we've got a colleague here in the audience, when they see a low iron and low ferritin and an anemia, it looks like iron deficiency, they treat with iron. And that's very alarming, because then you don't respond, and then they think, well, there must be some subtle iron loss somewhere, so you get investigated, because that could be through your intestinal system, and particularly males, because they very rarely get iron deficiency. But what we know is that many people won't respond to the iron tablets, so it doesn't go up, nothing changes. They just get side effects of iron tablets. So what we kind of propose now in terms of iron is that it's clear that iron supplements can make EPP worse, because you're giving iron, you're encouraging the bone marrow to make more blood, and of course you can only do that, and protoporphyrin level go up as well, because you have an overproduction, and that's probably why they get worse. So our recommendation now is that only treat iron deficiency if the patient is anemic with symptoms. So we're talking about someone whose hemoglobin is kind of low enough, not mild anemia, but low enough to be causing them tiredness and, you know, not feeling very well, etc. And if you are going to treat at a low dose over the winter months, so that if they do have a rise in protoporphyrins, then they're not actually needing, they're not going to get exposed to a lot of sunlight. So, and at the same time, keep an eye on and monitor their liver function by doing blood tests to make sure there isn't any damage to the cells of the liver. So those are the 3 things we now recommend for our patients. However, that doesn't apply to XLEPP because it's a completely different condition, and the way iron and heme is made is different. So in XLEPP, we do the opposite. So we treat them with iron because iron can lower their protoporphyrin levels. And it's possible that some of this was why in the old days this was all muddled up in the literature. So does that all make sense? So by all means check the ferritin every year, but the key is don't treat it unless the hemoglobin is low and he's feeling run down or weak or whatever. So hemoglobin low is, particularly low as well.
I was diagnosed at the age of 24, and prior to that, I used to take iron supplements every day, but I noticed that I would actually smell of iron, so I stopped because it was off-putting.
What does iron smell like?
Like a metallic smell. You can smell the iron supplements, you'll know.
Fortunately, I've avoided that. So I'll have to go to our pharmacist and ask if I can smell an iron tablet, I think. Okay. Yeah. Yeah.
That's an interesting point, because one of the things that Susie said when I have a phototoxic reaction, she says, I can smell it on you. I wondered if anyone else with EPP, has that.
How old is he? Oh, yeah. 15-year-old boy smells. We met? Okay. Does anyone else think that they smell different when they have a severe reaction?
Just discuss with a gentleman here. When we've had phototherapy, after exposure in that context, there's a unique smell.
Scent on your body, not in the cabinet. Okay. Okay.
Smells like skin.
Burning. Okay. Well, that may be the phototherapy. Okay. Well, now I've learned something else. So protoporphyria smells. You can smell it. You definitely think you can smell it when he's had a reaction, though. Not every day.
With my children, I can go to the doctor and say, and they say, how do you know? I say, because I've got that fibre smell, and he goes, what's that smell like? And I go, smell it. And it's like a gastric smell. And he goes, when the mums know the gastric smell. And then when he's having a reaction, it's like a total different smell. It comes like a...
Well, you heard it here first, guys. Yeah? Yeah.
Can we edit this?
Yeah, I think... Scent, we could do, yes. We may need to edit that bit. Or don't let him watch it.
Just to pick up the point that the ladies mentioned as well, we've had this experience that we go to the GP. We've got a brilliant consultant dermatologist, but we go to the GP and he noticed iron levels were low. I tried to explain, well, this is just part and parcel of EPP. He wouldn't take it. Very nice doctor, but got sent to the consultant paediatrician, who again didn't fully understand and was to say that this needs to be monitored. So how can I get the message over to these guys who are doing a brilliant job? But, because I did say go to the Porphyria Society's website, but I don't know if they would take that word. I mean, how can we get the message through to the GPs and the consultants? It's not required.
Well, that is still a site problem, but they can write to us And you could say this was discussed at a patient day, and the experts there do not treat everybody with iron all the time. But going back to what I said, they will be worried that a male youngster has a low ferritin and maybe a mild anemia, and they will see that as a sign of some other pathology. Yeah. So get them to write to me, or get them to write to who do you see a photodermatologist at all?
I do, yes, in Leeds.
Okay.
Dr. Golden is brilliant.
Okay. Do they know about this?
No.
Okay. Get them to write to one of us, to myself or Prof Stewart, and just, to clarify it if they don't want to believe you.
Our dermatologist put my son on iron, but then we went to see Dr. Sartney in London, and he said, no way, don't put him on it. But what he does now is each year when we go to see him, he writes to our GP and he writes to my dermatologist at our local hospital, explaining all the results, and in big letters he's put, do not give this patient without contacting us. So maybe Dr. Goulding could copy your GP in.
Yeah. Thank you.
Okay.
Could you briefly describe the symptoms of overdose of iron, so that we know if you know them?
Overdosing of iron it's generally a problem when children get hold of mum's iron tablets during pregnancy. You have to take quite a lot, and it causes nausea and vomiting. It causes irritation to the gastric. Like those who've taken iron, you get that. Even on a normal dose, your tummy gets upset. It's not very nice stuff to take. So iron toxicity, overdosing on iron, if you're taking a little bit too much every day, like people here there would be no symptoms of it. Your body can store really quite large amounts of iron before it becomes really damaging to the liver or to the heart or other parts of the body. Acute iron poisoning is usually an overdose of pills, and it's usually children, or I presume occasionally people who are trying to commit suicide and take them in addition to other things. But it's very irritant to the gastric system, and there are treatments, so it's quite an unpleasant experience, I believe. Okay, so we can talk about that. Another thing I wanted to just talk about was bone health. And somebody talked about this earlier, mentioned about calcium and vitamin D. What happened?
Well, James started having symptoms, which was lightheadedness and dizziness, where he couldn't lift his head off the pillow. He was having heart palpitations, bad abdominal pain, vomiting. We phoned 111, and because he was having the palpitations, they told me if I didn't take him to the hospital straight away, they were sending an ambulance. So we went off to the hospital. They said he was viral. I told the hospital it wasn't viral. They sent him home.
He didn't smell right, did he?
No, he didn't smell right. So it happened 3 times, and on the 3rd occasion, I actually got a doctor that listened to me and explained that he's always vitamin D deficient. He just had his blood test done, but we hadn't had the results. He went and checked them, saw his vitamin D was through the floor and needed proper vitamin input, and he decided then he was going to test his calcium level, which is also on the admittance line of him staying in the hospital. And he said if I hadn't have fought for my son and made him listen to me, he would have sent him home again viral, which could have been had a dramatic effect on James with his calcium. So, yeah.
Well done for sticking to your guns. Yeah. So the reason why I'm raising this is because I talk to a lot of patients about vitamin D, and I'll tell you what we say, and what meds you're on, this, that, and the other. They forget to mention vitamin D. They might say, what about vitamin D? Ooh, yeah, now I am on it, but I have to be honest, I often don't take it. Bear in mind, if you have EPP, you have a condition which means that you don't make your own, or you make very little of it. And you are therefore at risk of vitamin D deficiency. And the importance of that is not, vitamin D is actually vital for healthy bones. You won't feel it now, you might not feel it in 10 years, but what it will do is it means that your bones are not mineralizing as well as they should be. And as you get older, you will become at much higher risk of osteoporosis than anyone else in the population. And the Dutch have done a study on all of their EPP patients and shown that the incidence of osteoporosis is much higher than any other population of patients and the general population. So the message from today is look after your bones, and vitamin D is only one aspect of that, but it is very important. The other thing you need with vitamin D is calcium. So, because the vitamin D helps you take up calcium and store it properly. So you need to make sure you have enough calcium in your diet. You can go online. So these are dairy products or supplements. And there's lots of online, you put what your daily diet is for a week or something, and it will tell you whether you're getting enough calcium for you or your children. And if you're not, you can get vitamin D and calcium tablets. They're all in one. The other things for bone health that we all talk about to our patients are regular exercise. Not that easy if you've got EPP and need to go outside. Vitamin D supplement and not smoking. And I put here daily versus weekly because your GP, if you're the sort of person who doesn't like taking a tablet a day, okay, go and see your GP because you can get, doesn't matter, you can take big doses once every week, once every 2 weeks, etc., so that you only need to remember that one capsule every week or every 2 weeks. So you can take them all in one go, if that's what the issue is. Yeah.
Hi, my name is Mark Farrer. I'm a research scientist at the University of Manchester, and I work on photosensitivity, which includes EPP, and one of my areas of research is vitamin D acquisition. And we have a number of people coming to us that have said, I've been to my GP, I've been told I've got low vitamin D, they've said to take supplements for a few weeks and then stop. And that's not good enough because as soon as you stop, the levels come down again. So I'm interested, is everybody aware that they're at risk of low vitamin D? Yeah, and also it's very important for children because, as Mike was saying, during your childhood, particularly around puberty, you put on about a third of your final bone mass. So if you're not getting the vitamin D and you're not getting the calcium, you're not going to make that bone mass and your bones are going to end up weak.
Thank you. Thank you. That excellent corroboration of that. I mean, vitamin D's become very fashionable, and I understand that, but for you guys, it's not fashionable. It's essential, because what you don't want is to be having hip fractures in your 50s because you didn't take notice now. There are other treatments for bone thinning, so it's not the end of the world, but why not just prevent it? So we've got a 5-minute warning. Perhaps we could just go around and ask people have additional questions that they would like to talk about.
As well as being tired, which was down to my anemia, Dr. Sarkany also suggested there could be low thyroid, which actually I had all the tests and I was as well. So sometimes it's not always, your tiredness it's something that normal people get as well. So add that.
Good point. It is still important that when you have a symptom, the doctors even with porphyria, don't forget, you can still get common things. And the underactive thyroid is very common in the general population. So any condition which is relatively common, you can also get. And it may not be that some of your symptoms are just due to protoporphyria. I have to say that a lot of clinicians will blame the porphyria first and then think of other things after. So I'm just going to go here next.
Hiya. I've got two questions. The first one is, why is it my feet and my hands are the worst when exposed to the sun? The rest of my body I can expose for quite a bit of time before it will affect them. And secondly was, When I was 22-year-old, I went down the beach with my pals. I was playing football, and it was absolutely horrendous. It was the worst ever. I came out in big blisters and ended up in the hospital, and that's where it was diagnosed. Dr. Cheeseborough, you might know him now. Well, 2 weeks later, when it all died down, I went down on the beach again, in exactly the same kind of weather, and not a problem. I had no problem at all, so I just don't understand it.
Well, like many clinicians, I could guess, but I don't think I have an answer. The thing about the hands and the feet, of course, for the hands are the most commonly exposed areas of our skin as people living in the UK. I don't know about the feet. It may be that, if you can see on the back of my hands, I've got a lot of blood vessels. The skin is relatively thin, not the front, but the back of the hand. And actually, it's very richly supplied with blood because, of course, you've got lots of fine nerves, you've got fine muscles and things. So it may be that this is, and you have a good blood supply, and that's probably the reason. But I am guessing. I don't actually know. And I certainly don't know why feet, because you'd think feet are covered most of the time. So I don't know. As to that very severe reaction, I think sometimes people, when you're active and your skin is being cooled all the time, you tend to forget that this reaction is happening. And it's only when you come in out of the cold and the wind, etc., and you realize you've been caught out, perhaps that. And certainly if you expose an EPP patient's skin enough, for long enough, and so you will see blistering, you will see redness, which is the blood vessels bursting under the skin and leaking blood cells into the skin. So I suspect you were having fun and you didn't realize it, and you just pushed too far with that and ended up with a very severe phototoxic reaction to the point where your skin broke down. So next.
Can EPP get worse? So she was diagnosed, she's on the lower end. Can it get worse? Could she end up with severe EPP as she gets older?
The short answer is I don't know. So we do know. I do notice that blood porphyrin levels can climb slightly from, sort of her age as you get older towards sort of early 20s. But I don't know whether that correlates with. Certainly, there are children with quite severe photosensitivity. So we just hope that yours never changes, and that we've got adults as well with pretty mild symptoms as well. So I don't know. Does anyone else want to comment?
Well, mine's different, but...
Just ask this young man at the back. You're going to respond and say...
It depends, what you want. Do you like the reactions that you get from the sun? It's mine used to be not too bad, but then, as I've got older, it's, changed to my face more, and, my ears and my nose. It's, my reactions have changed, from going through puberty and, stuff like that.
Thank you. So, yeah, it is possible. So you think it's got worse as you got older? Yeah.
I've got an 11-year-old son, and he's really sporty. He plays in academies at football. But when the weather gets really warm, and I've spoke to this gentleman here, his kids are the same. His fitness levels really do drop when he's tested, on bleep tests. If he's doing a bleep test in the summer compared to the winter, in winter he's far beyond what he is in the summer. So is there anything he could be taking as a supplement? Is it D that he may be insufficient with, or
is that not to do with the fact he's not able to train as much during the summer? No?
It just seems to really have an effect on. I didn't know whether, because when you get DOMS, you know what DOMS are. That's a blood problem, isn't it? Your body's got to get rid of that DOMS.
DOMS?
Delayed onset of muscle soreness.
Okay.
Fatigue.
Yeah.
So your body has to filter that out.
Yeah.
Is it maybe that you can't cope with the?
I don't know. I've never heard that described before. Do you think that his his approach to summer, does it change his mood? No? Do you think this is a mood thing? Because, look, if you're a young, active person, male or female, And
I spoke to Anthony.
you're,
You know Anthony?
yeah, yeah.
And he said he has the same problem.
Okay.
So he said it was a good point to bring up with somebody who
Yeah.
may be able to fill that question.
He's giving me a large T signal now. I don't think it means a cup of tea. I think it means time out. So,
I'll just bring out, Anthony, a point we were talking about earlier, when you said you're more fatigued.
Yeah.
When you're training for doing
in the
what
summer.
you do.
If I have a reaction, I've noticed the ball strength drops.
It's like dropping in the summer and rising in the winter. Is that
I suppose that could be part of it. I don't know. I don't think anyone's ever studied that.
Because there must be athletes out there what have got EPP, and maybe that's something that I did look on an American site where there's an American footballer.
Yeah.
He brought up the point, but I don't. Obviously, there's not much research, is there?
No, none that I'm aware of.
From a sporting point of view, he's the same.
Yeah.
You generally feel fatigued anyway if you have a reaction. I play a lot of sport.
Yeah.
Play a lot of cricket.
Yeah. It is one of the effects of a severe reaction is chronic fatigue, yeah. At least for a period afterwards. Anyway, I am sorry that this great discussion has had to come to an end. I hope we covered at least some of the things you wanted to talk about. And see you at one of these next time.
So we can probably pick it up in the social as well.
Yeah.
Thank you very much, Mike. And there's a comment on your running of it that we want to keep talking. Thank you.